2, 1.
Okay. Hi, this is Dr. Yates. This is answering the question about should the doctor be present in the room? How much should the doctor be present in the room? I see this on the forum. I've already answered a little bit, but I just want to explain to you what I think the course of action should be during the day. What we want to do, this is a medical profession. This isn't like going to Burger King. This isn't like going through a drive-through. This is real medicine. This is transplantation. When I was in hospital medicine and I was a professor of surgery, trust me, you had to be there for the entire operation, supervising it or doing it, whether the operation took 5 minutes or 5 hours. So it doesn't make a difference if you're exhausted. That's the reason why people are paying you for your expertise. If you're there taking out somebody's pancreas or liver or whatever, and it takes 10 hours, you stay there 10 hours until the job is done. I believe the same thing should carry on with hair. And a lot of people say, well, God, the doctor's going to be exhausted, so forth and so on. You have trained for this your whole life to make sure that the outcome is the best outcome you can have. Now, that's saying that. There are a lot of techs that can do a great job. I'm not saying that. But since you are the doctor, I think you owe it to your patient to be there to give the best outcome. So let me just tell you how the day flows here, and it flows in most places. So when the patient comes in, we've already met with the patient, all the goals have been set, expectations have been set. We go through a medical history because this is a medical office. Then on our board here, for our techs and everybody on my staff and my nurses, we plan out strategically what we're going to do. And it'll look something like this. Say, hairline. We'll draw something like that and say in this area of the hairline we want 500 grafts of ones that are very fine grafts, okay? Behind this in the hairline we might say now we want another 2 rows of 2s that are very fine hair, and then in the mid-scalp we want these grafts, and in the vertex we want these. Then in the temples we'll draw another diagram over here and say we want X amount of ones in the temples with only fine hair. So therefore, we're putting together a complex plan of how we want this hair. We just don't, draw and say, okay, put 1s and 2s and so forth and so on. We have a detailed map of how we want this to go. So the day starts there. Then next, we move to the patient. I draw the hairline. And when we draw the hairline, and I've already gone through what I go through to draw the hairline, so this is kind of, everybody's hairline's different. There are no 2 hairlines that I'll go in and just draw this. Okay, this is this man's hairline for what we're doing today. So it's no Burger King rule of how to draw a hairline, 4 fingers and 1, 2, 3, because if I do 4 of my fingers on everybody's head, my fingers are pretty big. Your hairline's going to be here. So all those are a guideline. So we use the guidelines, measure what we think should happen, we all agree, we take pictures. Okay. From there, the donor's prepared, we're doing FUE, or we're going to do the artist. We shave the back. We divide the back into 14, 16 boxes, or whatever we think is appropriate for the case. The patient is placed in a stretcher, or if we're doing the artist, is placed something like this. Throughout the whole harvest, I will harvest all the grafts because I'm the doctor and that's what I think I should do. And like I said in my post, it's easier to control the quality of 1 person than the quality of 5 or 6 people. Say if I'm not doing the harvest and I'm having somebody else doing the harvest, I have no idea what they're doing. And they might be good, But I control the harvest. We check the transection rate. We check the transection rate every 100 grafts. Why? Because the grafts have to be good. If you're cutting the grafts up, they're no good. And that's why, FUE has gotten a bad name. So I will do the entire harvest, whether we're doing 1,000 grafts, 2,000 grafts, or 3,000 grafts. And we can do 3,000 grafts in a day. We've just progressed to that. In the beginning we could not, but now we can because we've kind of speeded up some of the steps. So after that is done, the grafts are extracted. We treat the wound back here. Then we go to the placement. Usually on average we can do about 700 grafts an hour, so a 2,000 graft case is going to take about 3 hours for me to harvest. We go back up here, this area is numbed, The recipient sites are made by me, all by me, all 2,000, all 3,000, and then the techs come in and place the grafts. I place grafts sometimes, but not all the time. Okay, the techs will come in and place the grafts. So usually we can get a case done like this, say a 2,000 grafts FUE case. We're done by 4 or 5 in the afternoon. And then after that, sometimes we put the patient under the laser or different things we do to accelerate wound healing. We use PRP in the back. I think PRP is very important. But I want to say this. I think the doctor should be very much involved in extracting the grafts. Extracting the grafts is not easy. It's something you cannot go to a course and learn in a weekend. You can't do it because you can see all these holes back here that looks like the doctor did something, but if the quality of the graft is not good, when they plant the hair, it's not going to grow. It's no magic, no hocus pocus. If you get good plants here, treat them appropriately, no trauma, place them appropriately, they will grow. And the benefit of FUE is we cherry pick the hair. When you do a strip, say for instance the same patient, you take a whole strip out, you're taking this much of the skin out and putting it back together. It's like the analogy I was saying of taking your pants and cutting them and then trying to close them again. Of course you have excess skin, but it's just a limit on how much you can do. So with FUE, the areas of the scalp I can easily punch like this behind the ear, that if you cut behind here, everyone knows this is where the scar spreads. 9 out of 10 guys, when they come back and they've had more than one procedure, they have a big divot behind this ear. I don't care who does it. I do it, anybody, any big name, you pick a name. This area is going to spread a little bit. With FUE, we can get to this hair and it's not going to spread. So, after the procedure is done, we treat the wound, with routine wound care, treat the top, and then ta-da, the patient is on their way. I know I've spoken a lot about FUE. I think it's the way to go. It's a skill. Somebody said, why is FUE so expensive, Dr. Yates? FUE is expensive because, like anything, the doctor is doing it the whole time. There's not any tech. There's not a big piece of scalp that we pass to a desk and everybody is cutting it while the doctor's doing something else. And there's nothing wrong with that. I'm just saying this is why it's more expensive. You are there the whole time, making sure each graft is perfect, the whole time for 2,000 grafts. So, in my mind, wouldn't you want to have that, no scar back here, making sure each graft is perfect, and have great grafts up here, then to save money, have a scar, and of course you'll have great results. There are fantastic doctors doing hair transplantation. Just look all over the Ball of Truth. Fantastic results. But there are fantastic results with FUE as well, without the scar. I'm going to say one more thing. If I had a nickel for every younger patient I've seen that was done in their 20s and now they're 30 or something in their 40s and they say, I have, my hair up here is not what I wanted in density, and that can be for a lot of reasons, okay? But I have this dumb scar in the back of my head. This is all I have. It's like I went to Disneyland and all I got was a dumb t-shirt, and they're mad. So if you don't have that scar in the back, and even if the hair up here didn't turn out like you want it, because usually the graft hair grows but you lose more hair, and you have to really understand that, then at least you won't have one thing back here to be mad about. It takes away variables. So, this is Dr. Yates. Hope you've understood it. What I want to make clear is this is real medicine. I'm a real doctor. The people on the Ball of Truth and the other forums are real doctors. This isn't fun and games. It's not voodoo. Real science is behind this. We're real surgeons with credentials. So any questions, just email me. I'll answer you right back. This is Dr. Yates. Thank you.